So let's review of this preoperative and postoperative. What are the nice guidelines for child who is undergoing tonsillectomy? BP is normal, blood weight, everything is normal. There is no need of any investigations. Now look at the diabetic patient. Type 2 diabetes, type 1 diabetes. What is the difference in type 2? This is on tablets. Patient tissues become resistant to insulin. So insulin, even if you give, it is of no use. So continue till morning. Stop oral hypoglycemics. Metformin should be stopped because it causes lactic acidosis. So type 2 insulin dependent, type 2 is insulin dependent, type 1 is non-insulin. Type 1 is insulin dependent because person I is insulin. Type 1 insulin because it requires insulin. As insulin is not produced in the body, patient is having pancreatic pathology, so patient needs to be admitted, multiple doses, stop fast acting and continue basal. Fast acting should be stopped. Infuse insulin according to variable scale. This is important. HbA1c 8.5% or 69. Postpone and elective surgery. Intraoperative every hourly after surgery. Intraoperative it should be 6 to 12 millimoles. This is question. Fluids, point for half normal saline, 5% excess, and potassium. Potassium should be added. If no potassium, patient should be taken on priority. Pulse rate variability. This is the question due to peripheral variability of pulse rate variability is there. May have orthostatic hypotension. Sliding scale till oral feeding is started. If the patient is on steroids, for example 10 milligram, less than 10, no need to cover. More than 10 milligram, increase the dose 25 milligram at the time of induction and give it for next 2 to 3 days 100 milligram hydrocort. Cortisol, it is more potent hydrocort. Short acting 8 to 12 hours. This is long acting is Dexa. Moderate mineralocorticoid property, less anti-inflammatory. Fluodocortisone, long acting. Prednisolone tablets, intermediate to long acting. So what are about so the thromboprophylaxis for children? There is no need any surgery. Risk of DVT, it is there more than 60 years of age, having more BMI, varicose veins, phlebitis, thrombophlebitis, hormone replacement therapy, OC pills, any surgery, any site more than 90 minutes, lower extremity more than 60 minutes or pelvis more than 60 minutes, abdomen, inflammatory condition, malignancy. These have got high risk, so you need thromboprophylaxis. Expected decrease mobility. If suppose you think person may not be moving, so that is called as decreased mobility. All patients talking plus low molecular. Peripheral vascular disease, only low molecular weight. Recent DVT, pulmonary embolism, vena cava filter. 35, less than 35, hypothermia, severe hypothermia, center is hypothalamus, common neonates, increased surface area, respond vasoconstriction. ECG is J wave, prolonged PR interval. Mild management, external warming devices, severe warm intraperitoneal fluids. Preoperative, ASA 2 to 5, preterm less than 36, combined GA and increased risk. Major or emergency surgery, Phase 1 before 1 hour before surgery, if temperature less than 30, elective do not operate, emergency active warming. Document temperature induced every 30 minutes. Incident reporting, if patient arrives in theater ambient temperature should be 21 degrees. Cover adequate intraoperative exposed during intravenous fluids. Warm it to 35 degree. Warming postoperative ward transfer less than 30 should be treated. ACE grading, no systemic disease, mild systemic disease, no limitations, controlled diabetic hypertension, smoking, alcohol will be 2, severe hypertension, BMI more than 40, uncontrolled diabetes, significant limitation, 4 is having risk less than 30%, ejection fraction, stent history less than 3 months, so it is 4, moribund is 5. Acute physiological for ICU evaluation, POSSUM for operative severity scoring, NELA, National Emergency Laparotomy audit, rapid enhanced recovery to decrease the hospital stay less than 30 days, pre-op counseling, so to under hospital stay, to decrease the hospital stay, pre-operative counseling, antibiotics before the start of surgery, this is prophylactic antibiotic, resting bowel preparation, carbohydrate loading, decrease insulin resistance. Why carbohydrates are given 2 to 3 hours before? It reduces the insulin resistance to avoid negative nitrogen balance. DVT prophylaxis, correction of the anemia, stop the smoking. This is pre-operative counseling and all the intraoperative multimodal analgesia. Different types multimodality of analgesia has to be given. Regional anesthesia is preferred. Then minimal invasive surgery is again for enhanced recovery. Antiemetics can be given. Avoid unneeded nasogastric tube catheter or prevent hypothermia. Fluid therapy, goal directed, should not be unnecessary overloading of the fluids. These are intraoperative and postoperative. Early ambulation, early nutrition, start oral, early removal of the catheter and the drain. These are the important points to be considered. Local anesthesia. Let's see, given local anesthesia, lignocaine blocks the sodium channel, which causes depolarization. Toxicity, first to come is cardio, neuro, circumoral numbness. Antidote is intralipid. Maximum dose is calculated without adrenaline 3 mg per kg, with adrenaline 7 mg. Bupivacaine post of local wound, spinal epidural nerve blocks, long duration 2 mg per kg is maximum dose, with or without. Prilocaine for a BS block. Antidote methylene blue, maximum dose again 6 mg without adrenaline and 9 mg with adrenaline. So adrenaline prolongs the action. Residual regional anesthesia. Spinal at the level of L4-5. Side effects are hypotension, headache, spinal hematoma, renal retention. Epidural, any level. Lumbar 8 thoracic. Infusion analgesia, better than patient controlled anesthesia in cognitive disorder as a Down syndrome. Caudal, children inguinal and hernia. Patient controlled analgesia on IV morphine. Tap block, inject, transfer. General IV agents, induction or maintenance. What are the cardiovascular effects and what are the disadvantages? Propofol is bad for cardiovascular effect, but it is painful both intramuscular and analgesia. It has got good analgesia and antiemetic property. This is the question of antiemetic property. Thiopental rapid induction, worst. Ketamine induction useful in shock, trauma, unstable patients, good. Etomide for induction, good for cardiovascular. What are the muscle relaxants? Depolarizing muscle relaxant is suxamethonium, non-depolarizing atracurium, vicurium. Histamine release is more with atracurium. Then hyperkalemia, suxamethonium causes hyperkalemia, malignant hyperthermia, delayed recovery. So antidote is dantrolene for suxamethonium and neostigmine for atracurium and all that. Inhalation anesthetic agents are halothane, malignant hyperthermia, hepatotoxic, isoflurane maintains, sevoflurane for the children, nicotinic acid, Nitric oxide is an adjunct. Different type of receptors are alpha 1 for the blood vessels causes vasoconstriction, beta 2 receptors, beta blood vessel vasodilatation, beta 1 for the heart increased contractility, cardiac drugs. Drugs receptors action use noradrenaline more than alpha vasopressor septic shock. Dopamine beta agonist increases beta contractility, decrease vasodilation, cardiogenic shock. Isoprenaline beta agonist increase cardiac after heart transplant in bradycardia. Dopamine low dose, high dose. Low dose D1 receptor vasodilatation, high dose alpha 1 receptor vasoconstriction. So renal and all this vasodilatation can be given in low dose. So these are